Hello, I'm Jack West, medical oncologist in Seattle, Washington, and also the president and CEO of GRACE, the global resource for advancing cancer education. And I'm here today with Dr. George Simon, who is a medical oncologist and the director of the thoracic oncology program at Fox Chase Cancer Center in Philadelphia. I'm going to talk with him about a few novel approaches in customizing chemotherapy by molecular markers, and also talk a little about some of the highlights of a conference that we are just at the end of, the World Conference on Lung Cancer here in San Francisco, which was actually the largest lung cancer meeting that has ever been assembled. So thank you very much, George, for joining me today.
It's my pleasure.
A transcript as well as a PDF file with copies of figures associated with this program are available at www.cancergrace.org/GRACEcasts. Can you please start with just explaining the concept of individualizing chemotherapy based on molecular variables?
Yes, currently the standard is to give a doublet chemotherapy regimen that is a combination of two drugs, and the two drugs are picked randomly. Usually a combination of carboplatin and Taxol, or carboplatin and Gemzar, or carboplatin and Alimta. However, we typically tend to see only about 25 to 35% of the patients respond to this treatment. Individualizing therapy is trying to figure out, by doing a genetic analysis of the patient's tumor, which patients are destined to respond and which patients are not destined to respond. If we can select out the patients who are destined to respond to a particular drug, say Gemzar or Pemetrexed or Alimta, we could then preferentially treat these patients with those drugs. If we know that they are not destined to respond, we can then treat them with alternative drugs like Taxotere or other drugs.
So rather than just shooting more or less blind and hoping that we do well and know that we only see responses in about a quarter of patients, the thought would be that if you could select based on the tumor characteristics molecularly, you might be able to improve those numbers.
That's precisely right.
So some of these markers have become increasingly used, or at least studied, in clinical work in non-small cell lung cancer primarily. Can you tell us a bit about ERCC1, what it means, and how it might be used?
So ERCC1 is one of the markers that is farthest along, and it is a repair gene. It repairs DNA damage. And drugs like cisplatin or carboplatin, basically salts of the metal platinum, they kill cancer by causing DNA damage. If patients have tumors with high ERCC1 function, then the DNA damage caused by these drugs is repaired, and therefore those patients will be resistant to cisplatin or carboplatin. And so in a way, by measuring ERCC1 and seeing how high or low its expression is in a particular tumor, we can figure out whether this particular patient is destined to respond to the platinums. A second marker that is also farther along in development is a marker called RRM1. RRM1 actually predicts for Gemzar resistance. And if RRM1 levels are high, then patients do not tend to respond to Gemzar. So similarly, we could biopsy a tumor, measure RRM1, and based on its expression, high versus low, opt to treat with Gemzar or not.
What would you say is the current status of these markers in clinical practice? Are they primarily research tools, or are they something that you think are or should be routinely used?
They have to be further validated at this point. Now, there is mounting evidence in clinical trials that are what we call retrospective, that these markers are relevant to predicting response and survival when treated with platinum and gemcitabine. We have done one phase 2 study prospectively that suggests that tailoring chemotherapy based on these molecular markers may improve response and survival.
That is the MADE trial. Can you tell us what that trial involved?
That trial involved taking patients with advanced stage non-small cell lung cancer or stage 4 disease, doing a biopsy of their tumors, and then measuring ERCC1 and RRM1. If ERCC1 was high, then we did not give them platinum. And if RRM1 was high, we did not give them gem. So we tailored the chemotherapy into 4 different platinum doublets. If ERCC1 was low, we gave them platinum, and if RRM1 is also low, we gave them a combination of carboplatin and Gemzar. If ERCC1 was low, we gave them carboplatin, but if RRM1 was high, could not give Gemzar, so we gave another drug called Taxotere. If ERCC1 was high, we could not give them platinum, but if the patient had low RRM1, we gave Gemzar in combination with Taxotere instead of a combination with platinum. If they are both high, we could not give platinum or Gemzar, so we gave them Taxotere and Navalbine. And then we followed these patients for response and survival. And we got better than what is considered average or normal response and survival.
So a couple of things to follow up on with that. Did you find that certain markers just characterized for not doing as well no matter what you gave? Or if you selected particular treatments for the molecular characteristics, you could get people to do basically the same?
Yeah, so certain markers like ERCC1 tends to predict that if it is high, platinum would not work. But it also, in a sense, tends to predict that if you use Taxotere instead, then Taxotere tends to have a higher probability of working in ERCC1 high patients versus ERCC1 low patients. This has been shown in retrospective studies, particularly with a marker very much like ERCC1 called BRCA1. High BRCA1 predicts for platinum resistance, but high BRCA1 also predicts for increasing Taxotere sensitivity.
How is the survival on this trial of tailored treatment plans, both early on and then in longer follow-up?
So we published our early results and we got a 59% 1-year survival. However, we updated these data just for this meeting, and we found that the survival advantage of tailored chemotherapy versus standard chemotherapy seemed to persist 4 years out. We were rather surprised by those results because most of these patients got only 4 cycles of the tailored chemotherapy, and 4 cycles are typically done in approximately 3 months. And I expected the patients to do better initially, but towards the later stages, I expected both the patients to do approximately the same. So the fact that the advantage to personalized chemotherapy persists 3 to 4 years out is a little surprising to me. We believe we have some explanations for this. However, these needs to be studied in more detail in future trials where we do serial biopsies.
So where is this work going?
Well, we are now doing a phase 3 study comparing patients or randomizing patients to the customization arm versus the non-customization arm. All the patients randomized to the non-customization arm gets carboplatin gemcitabine. If they are in the customization arm, they get one of those 4 regimens that were given on the MADE study. And then we hope to compare the 2 cohorts of patients to see who did better.
And this trial is being done at multiple centers then?
Yes, it's currently being done at multiple centers in the United States, and also a couple centers in Germany are participating.
Another marker that we've heard a bit about is thymidylate synthase. Can you tell us about what it is and where it is in the process of being used as a clinical tool?
So thymidylate synthase is the molecular target for Alimta, and people are now studying this marker in retrospective studies. In clinical trials that compared cisplatin and Alimta versus cisplatin and Gemzar, there appeared to be an advantage for adenocarcinomas for cisplatin and Alimta and for squamous cell carcinomas for cisplatin and Gemzar. And several investigators tried to understand why these differences were seen. As it turns out, because TS is a target for Alimta, investigators looked at TS expression in adenocarcinomas versus squamous cell carcinomas and found out that TS expression was higher in squamous cell carcinomas and lower in adenocarcinomas. And that's one of the reasons why it is believed to be a reasonable marker for Alimta, and one of the reasons why Alimta is postulated to work better in adenos. However, this marker needs to be validated in prospective studies.
Up to now, we've been talking about the advanced disease, generally stage 4 lung cancer setting. How is this kind of work moving forward in early stage, potentially curable non-small cell lung cancer?
So there are several studies that are looking at this strategy in trying to increase cures in early stage lung cancer. Most early case lung cancer patients are treated with surgery followed by chemotherapy. Up to now, chemotherapy in this setting is also randomly selected. However, there are several studies in the United States as well as in Europe which are looking at studying this resected tumor for their molecular markers and then giving the chemotherapy in a tailored fashion afterwards. Similar studies testing this concept are currently ongoing in the United States and in Italy and France and Spain.
There was some work that looked at ERCC1 as a marker of whether patients in the postoperative setting actually got value from cisplatin-based chemotherapy. Do you think that is a valuable way to approach the question in terms of should we even be giving treatment, or do you think it's really more a question of planning to give treatment but refining what drugs?
So ERCC1 has a prognostic function, which means that resected patients with high ERCC1 have a much lower probability of the disease coming back. And the different groups have taken a different approach to the value of this prognostic function. And as we previously talked about, it has a predictive function, which means that it predicts for whether platinum works or platinum does not work. So the French group have bought into the concept of prognostic function of ERCC1, and in resected patients with non-small cell lung cancer with high ERCC1, they are not treating with chemotherapy. The Spanish group, however, using BRCA1 as a marker, have decided to treat these patients with chemotherapy but with Taxotere. And the Italian group is also treating these patients but also with Taxotere.
Do you have a sense of whether ERCC1 and the BRCA1 marker are largely redundant, or is one better than another over time?
I think they are redundant, and the preponderance of data are for ERCC1. And ERCC1 has been studied by several different groups to arrive at the same conclusion, including our group in the United States and the French group and the Spanish group and some Asian groups. BRCA1, however, has been studied only by the Spanish group, has not been validated by other groups. Additionally, there was just an abstract presented at this meeting a few minutes ago, which looked at which would be a better marker, which looked at several markers, including ERCC1 and BRCA1. And the conclusions of this retrospective study, called the FAST-BIO study, was that ERCC1 was a statistically significant predictive marker, whereas BRCA1 was not. So the preponderance of evidence suggests that ERCC1, there is more data with ERCC1, there are more groups working with ERCC1, and then there are some data suggesting that ERCC1 may be the better marker.
You had mentioned that ERCC1 has prognostic value and that high levels of expression are prognostic for doing better. Can you tell us about why that would be?
We truly don't know. However, we believe that the function of ERCC1 is to maintain normal DNA, the normalcy of DNA, or what we in medical terms call genomic integrity. DNA is a chemical and has been stitched together to convey a certain genetic code. The code written on this DNA determines how tall we are, the color of our eyes, the color of our hair, so on and so forth. So nature, very early on in evolution, tried to protect this genetic code and instituted several systems in place. One of them was a repair mechanism. DNA is prone to damage when exposed to several insults, like ultraviolet radiation or carcinogenic chemicals found in tobacco products or in certain foods or toxins. So if DNA gets damaged after exposure to these toxins, then nature has invented a way of repairing that damage. Now, these tumors that arise from normal cells or arise from within us have inherited this ability to repair DNA damage. If tumors have a high capability of repairing DNA damage, then their DNA resembles and looks more like normal DNA. And these tumors tend to behave less aggressively and generally have a more slow growing, or what we call an indolent course. And hence we believe that these tumors are less aggressive and therefore the prognostic significance.
George, thank you so much for taking the time today.
It's my pleasure, Jack.